Welcome back to ACCEL for April 2017. I'm Alfred Beauvais. Disc 2 begins with a talk Allan Jaffe had with Dr. Charles Resor, cardiology fellow at the Brigham and Women's Hospital in Boston, Massachusetts. They cover impact of optimal medical therapy in the dual antiplatelet therapy, or the DAPT study.
Charles, would you start out by please reminding everybody what the design of DAPT was?
Absolutely. The DAPT study randomized approximately 11,000 patients who underwent drug-eluting or bare metal stent placement and were then free of ischemic or bleeding complications for 12 months. Randomized those patients to an additional 18 months of continued thienopyridine therapy versus placebo.
Which thienopyridines were used?
They used clopidogrel and prasugrel.
In standard doses? Or
That's correct.
And you then decided to look at whether or not optimal medical therapy made any difference in this group. Can you tell us how you define optimal medical therapy?
Absolutely. We define optimal medical therapy as according to Class 1 indications by the ACCEL and AHA, such that we defined all patients as having an indication for a statin, and then patients with a Class 1 indication for an ACE and an ARB or a beta blocker as being indicated for OMT, or optimal medical therapy.
And did you look at doses, or you just looked at on or off
We
therapy?
did. We did not have information on medication dosing, just on or off those agents.
And this was at the time of randomization, these patients were on these drugs?
That's correct. So 12 months after the index PCI at the time of randomization in the DAPT study.
But if they came off subsequently, did they change group, or they stayed in their initial group?
They stayed in the initial group.
And what endpoints were you specifically interested in?
We were most interested in myocardial infarction, MACI, which was a composite of myocardial infarction, stroke, or death, and then gusto moderate or severe bleeding.
And in looking at these patients, what in general did you find?
The primary results of our study were that the use of optimal medical therapy had no impact on the treatment benefit and risk of continued thienopyridine use, such that continued thienopyridine use resulted in consistent reductions in ischemic endpoints and consistent increases in bleeding endpoints in this population.
Were those groups the same, or were there differences?
There were significant differences between the groups. Patients who were on optimal medical therapy tended to be younger. They tended to have lower rates of hypertension, chronic kidney disease, prior PCI or MI.
So you would expect that they would have lower event rates.
That is correct. There were significant differences between the groups. When we made our comparison of the treatment effect within those two groups, we did adjust our interaction p-value for approximately 20 baseline characteristics, procedural characteristics, and then stent-related factors as well.
Can you give us some sense of the magnitude of these differences? Were they quite tiny, or were they substantive in nature?
There were some significant differences. There was approximately a 10% higher rate of hypertension in patients who were off optimal medical therapy as compared to on.
But I'm talking more about the results in terms of MI and MACI.
The hazard ratio for the reduction in MI for patients with continued thienopyridine on optimal medical therapy, their hazard ratio was about 0.6. The hazard ratio in the off OMT group was about 0.4. While there is some suggestion that the patients off optimal medical therapy derived a somewhat greater benefit, when we used our interaction analysis, the interaction p-value did not meet our criteria for significance, suggesting that there is a consistent treatment effect between the two groups.
But were the absolute rates different between the optimal medical group and the non-optimal group?
There were.
And it's significantly so, or not significantly?
There were significant differences in the rates of all three outcomes between the groups.
And was there a cost in terms of bleeding, and how did you measure that?
So our outcome was gusto moderate or severe bleeding. What we found is that patients off of optimal medical therapy did have higher bleeding rates irrespective of treatment arm, of the treatment they were assigned to, but that when randomized to continued thienopyridine use, there was no difference in the increase in hazard and bleeding between the on and off OMT groups.
And did that interact with outcomes in any way?
The bleeding outcome, so again, no significant difference of the treatment effect between the two groups.
Of the two thienopyridines that you used, clopidogrel and prasugrel, was there a difference between those two?
So within the primary results of the DAPT study, there were no differences in ischemic or bleeding outcomes with difference between the two thienopyridines used. Our results, when we adjusted for the type of thienopyridine use or did not adjust for it, our results were not different.
although you didn't see more detriment, you didn't see more benefit with prasugrel, which is of interest.
Right. So we didn't specifically compare the two outcomes, but when we adjusted and did not adjust, we did not see a difference in our event rates.
One final question about the treatment effects is that these people were on varying doses of aspirin. Was there any signal that the varying doses of aspirin affect these results?
So we didn't specifically look at that in our analysis, but prior to reports of the DAPT study in the supplementary appendix, and the primary results did not show any significant heterogeneity between the two doses.
I'm thinking about this. One could be on off-optimal medical management because one missed an ACE inhibitor or an ARB or a beta blocker or a statin. Did you see any differences in terms of which drug was not present that defined a person in the non-optimal therapy group?
It's a good question. When we looked at the treatment benefit of continued thienopyridine use across patients who were on or off a statin, beta blocker, or ACE inhibitor or ARB, we did not see any significant differences, no significant heterogeneity between the two groups when looking at the treatment benefit of continued thienopyridine.
Right. The principle of thienopyridines benefiting goes across the groups. Were there differences in the absolute rates across those groups?
There were in the on or off individual components of OMT, there were differences. It did appear to us that patients on a statin or off a statin, there was a significant difference in outcomes for those patients, similarly with on and off beta blocker. Less so for the ACE and ARB group. However, for that comparison of the on versus off OMT components, this was a non-randomized comparison, so we do think that there's a significant potential for residual confounding, and our conclusions, we feel somewhat less strong about drawing those comparisons as we do about saying that there's a consistent treatment of benefit across the three groups.
Certainly reasonable. Where do we go from here in regard to DAPT then?
Excellent question. I think that the main conclusions of our paper are that the decision to continue dual antiplatelet therapy beyond 12 months should be made irrespective of OMT use.
Because the rates were likely somewhat lower in the OMT group, despite the fact that you continued or didn't, you would certainly urge optimal medical therapy.
Absolutely. We would always say that your focus should be placed on continuing optimal medical therapy as much as possible. However, whether or not patients are on optimal medical therapy should not impact the decision to continue the dual antiplatelet therapy beyond 12 months. But you're absolutely right.
Thank you very much.
Thank you very much.